to speak on 6-month outcomes of corneal wavefront guided PRK for keratoconus in 467 eyes. I will ask you to take a little bit less time because the president, Miltos Balidis, we are very late and he asked me to shorten the session. So please, could you try to do the talk in like 6 or 7 minutes instead of 10 minutes?
Thank you very much for this congress, and I will present in short time surface ablation about cohort. So surface ablation with excimer laser associated with or not with cross-linking. So the major goals is the reduce of high order aberrations, improvement of visual acuity, of quality of vision, improvement result of the other procedures like cross-linking, intracorneal rings, phakic IOLs. I think intracorneal rings are just the first line of treatment, and we have always, not always, but lots of cases complete with PRK to reduce the dependence of rigid contact lenses. The objective is not to get rid of glasses. So preferable stable keratoconus more than 450, Kmax not very high, and asymmetry less than 10 diopters, and it should be a requesting patient, intolerant of contact lenses. So we have to carefully study the psychological profile of the patients, because patients confuse between PRK for keratoconus and LASIK, or PRK for refractive surgery. So they should understand the principle. The technique should be always transepithelial. This is because the epithelium is irregular and we cannot remove it with a brush. So I have no time to detail all this. So the timing of cross-linking, when the cross-linking is done before so we can do only PRK, or when the patient have no previous cross-linking, we do the cross-linking in the same session. So I perform the both techniques. So the aim is to flatten the steep areas and the flat areas. There is a small video, but I will pass, no time for this. Should we treat the cylinder? I treat the cylinder when I can. I put high order aberrations as the first aim, and then put cylinder when I can. It's preferable to get rid of astigmatism. So aberration profiles are not regular like in ametropic refractive surgery, but they are the same profile like aberration that we will treat. So have a lot of I do it with technique, no touch. Just no technique, just with my fingers. I open the eyelid and do the laser, and then cross-linking just after. So this has result in 3D. When we show this to patients, they are very happy. So before, after, and what is good here is the PSF. We see the PSF before and after, and the quality of vision is better. So this is some before after surgery. So it's in the right here we see that the deformation is still there, but it is due to aberration of the posterior surface. This is only the anterior surface. Even when we have deformation in the anterior surface post-surgery, it doesn't mean that there is a failure, but the quality of vision is getting better. This before, after, lots of cases. Though we have, this is PRK after intracorneal rings. I just try to find out the deepness of the ring. It should be deep, and I try to avoid the extrusion to not be very deep in ablation. So this is cases before, after corneal, intracorneal rings. It gives very good results. So we have here some clinical cases. Look, the visual acuity is getting better and better after this kind of surgery. I don't have time to detail all this. I take in consideration the pupil, the myopic pupil, and the patient sometimes told me I see good at the day but very bad at night. So I try to put larger optical zone to treat the night glare. So this is I do treatment with MS39 guided treatment by Schwind. This is the platform. So I put corneal wavefront, total wavefront. I put the cylinder when I can. Trans-PRK. I choose the epithelium, the thickest epithelium in the 5 millimeters area. The same here. And I confirm the treatment. I choose the optical zone and treat. I choose when I can all the aberrations, and sometimes I reduce some aberrations using minimize or minimize plus, volume or depth. It depends on cases. So there is no one way for all patients. We have to optimize. It depends on every case. So this is another one. These are results. Don't 6 out of 10. We can go to 10 out of 10. Sometimes patients get rid of glasses, but we don't have to promise that they will get rid of glasses. Other cases. So about 467 eyes, we have improvement of uncorrected visual acuity, best corrected visual acuity, reduction of K-maps, and reduction of Q value. And we will see these cases in 1, 2, and 3 years. So in conclusion, it's a first line treatment. When I can do a PRK when I have the ablation depth very small, and I can do it. I prefer it to other procedures. It's precise, long-lasting results, and it's safe, and we have really stable results after time. And thank you very much.
Thank you very much. Thank you very much for accelerating. I'm sorry about this. So the next speaker is Alvin Nazirov, and please, can you...
How much time?
Okay.